This is my series on how to read a research journal. We're going to go through how to read a study based on a new study, GLP-1 receptor agonists and the risk of fragility fractures in older adults with type 2 diabetes. This was just published July 2026. So first I look at what type of study was this. This was a population-based retrospective new user cohort study. That's what it says right in there. You can read it. Well, here's what each part means. Population-based. It included patients from a nationwide healthcare system, making the results more representative of routine clinical practice. It was retrospective. They looked backwards at data that had already been collected, not as good at looking at new patients prospectively. But it was a new user cohort. They only included patients when they first started a GLP-1 receptor agonist. This avoids many biases that occur when people have already been taking the medicine for years and years. Cohort study. People were followed over time to see who developed fractures. Why is a new user cohort better than many observational studies? Many observational studies compare people taking drug A versus people not taking drug A. The problem is that long-term users have already survived early side effects, and many differ substantially from non-users. By studying new users, everyone begins at roughly the same point, making the comparison much fairer. How did they try to make the groups similar? That's also important. Because patients weren't randomized, the investigators had to use other methods, and they use these advanced statistical methods: propensity score weighting, inverse probability of treatment weighting, multivariate survival analysis, competing risk analysis of death, intention to treat approach. These are statistical techniques that attempt to make the treatment groups resemble each other as much as possible based on measured characteristics. So what are the strengths of this kind of study? It has many strengths. This particular, I'm looking at the sample size. They had 46,000 adults, real world patients. Included only adults that were over the age of 65 with type 2 diabetes. So that's important. I'm thinking, okay, does this apply to younger people? The median follow-up was almost 35 months. So pretty good amount of follow-up for seeing if a fracture happened. They compared GLP-1 meds with other diabetes meds rather than untreated patients, and that's probably more fair. And they used these statistical assessments we talked about, and they looked at, interestingly, clinically important fragility fractures rather than just bone density. All those things we're noting. Now, what are the weaknesses? And this is very important. No matter how sophisticated the statistics are, the study remains an observational study. This means confounding by indication. Doctors don't randomly prescribe medications. Patients receiving GLP-1 drugs, and I've said this many times, may differ in important ways than patients receiving SGLT2 inhibitors, DPP-4 inhibitors, different diabetes meds. Some of these factors are not fully measurable. Number 2, residual confounding. Statistics can only adjust for variables that are measured. They cannot adjust for things that aren't measured, like frailty, very hard to measure, protein intake, if it's not tracked, calcium intake, which often isn't tracked, vitamin D status, which often isn't noted in these, muscle mass, fall risk, exercise habits, sarcopenia that's pre-existing. If these weren't measured well, and they're usually not, they can still bias the results. Through no proof of causation. The study found an association, not proof, that GLP-1 medicines caused fractures. So what did the study actually find? The investigators reported a hazard ratio of 1.11 and a 95% confidence interval of 1.01 to 1.21. So how do you read that? What does that mean? A hazard ratio, HR, of 1.11 means that during follow-up, GLP-1 users had about 11% higher relative risk of fracture than the comparison group. The confidence interval barely excluded 1. It was 1.01, meaning that the finding was barely statistically significant. Whenever you have a confidence interval that crosses 1, it's not significant. If it's very close to 1, you have to be careful about interpreting that as significant. So I would summarize my assessment of this paper that this is a well-conducted, large observational cohort study that raises a potential safety signal regarding fragility fractures in older adults with type 2 diabetes. But because the patients weren't randomized, there's residual confounding that's possible. The finding should be viewed as hypothesis generating, interpreted alongside alongside randomized trials, bone density studies, and the known benefits of GLP-1 receptor agonists on cardiovascular, renal, metabolic outcomes. Other thing to remember is you need to also take into account all the other things that have been published, because true research will be replicated in other places. Right now, there's a lot of other studies suggesting that these medicines might be beneficial in type 2 diabetes and fracture. There was just another published where it actually improves fracture risk in patients with diabetes. So you have to take this all into account alongside other research. When you read a cohort study, I want you to ask these 5 questions. Was the study randomized? If not, think this could be associated but not causation. How comparable were the groups at baseline? Did the investigators use propensity scores or other methods I talked about? Could important confounders have been missed? Did they look at nutrition, fragility, exercise, socioeconomic factors? They aren't usually captured. How large was the effect? A small effect size, like a hazard ratio of 1.11, are more susceptible to residual confounding than large effects. And lastly, how does this fit in the totality of evidence? Again, a single observational study should be weighed alongside multiple randomized trials, meta-analysis, and other mechanistic studies before changing your clinical practice. What questions do you have for me below?